You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete endoscopy in the majority of the case.
With absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah,
very good.
Yeah.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete endoscopy in the majority of the case.
With absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah,
very good.
Yeah.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete endoscopy in the majority of the case.
With absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah,
very good.
Yeah.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case.
with absolutely no risk to the patient.
Yes, we can see it. We can see it. Very good. Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case.
With absolutely no risk to the patient.
Yes, we can see it. We can see it. Very good. Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case.
With absolutely no risk to the patient.
Yes, we can see it. We can see it. Very good. Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah.
Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah.
Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah.
Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, So you have this brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah.
Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have this brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it very good. Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have this brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it very good. Very good.
Take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have this brighter, very high quality images.
The advantage of this system is that you can achieve a complete enteroscopy in the majority of the case
with absolutely no risk to the patient.
Yes, we can see it. We can see it. Very good. Very good.
take the mucosa inside and then pull it back.
I am ready now.
This is very important.
You need to adapt.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type.
Okay. I don't see me.
Okay.
Okay, welcome everybody. It's a great pleasure, it's a great honor to be here. I see Thomas, very elegant Thomas. So I have to say that I feel so emotionated on introducing this endoscopy, and we have been working for the entire year with a fantastic team, and we are preparing so many live cases. We are going live for 12 hours. It's exhausting, but it's very exciting as well. So I have a couple of words to be said. So the first one is thanks everybody, and I'm very grateful to the team. I'm very grateful to the faculty, to the sponsors. I'm very grateful to the physician getting connected. That's a very big issue for us. And I also very grateful to the technician. They are working restlessly to go live. So as announced on socials, for the first time, we are going live on our website, and we are going live on all socials. So if you want to watch on Facebook, Twitter, LinkedIn, Instagram, whatever is your social, we there, we will go live. We will be there live for 12 hours. So I don't need to say anything else. I have just a couple of sentences. This is, guys, for all of you. We want to thank everybody. So globally, locally, we love you. And we want to tell you what is happening now on socials. So we have 512 people connecting every second in the last minute. So this is incredible number. So we are multiplying, we are going to over 35,000 now in this time. And we are not estimating Chinese friends. I know in China, there are already 20,000 people connected already since 30 minutes. So welcome also to our friends on the other side of the world. And this is my final one. This is for Thomas. Thanks, Thomas. It's been a great job.
Thanks, Ale. Thanks very much. So I also have to thank you. You are like a Maserati driving this ahead. And it was a great pleasure preparing. We got in contact with many people, had many talks, and like in a script, film script, we were agreeing on what we would be showing and not. Because live endoscopy nowadays, I think when we think back, Ale, their first live demos 20 years ago, it was kind of uncontrolled. It was like the Wild West, wasn't it? So we invited people for impossible cases. But now I think the big advantage of this one is everybody stays at home and performs in the environment he feels safest and is probably best. We also have to say that the idea was born when Corona was still a beer, right? And we were thinking, what could we do next? And Ale had an extremely successful meeting. And I think I already told that, but he's the first person I ever met who said, after 10 successful meetings, I just stop. Usually you go on with your meetings until, I don't know, somebody carries you out. But this was the opportunity to think about something new. And Ale was extremely inspiring, and so we had ideas banging back and forth, and really, thank you to you. It's an enormous pleasure to work with you, at an enormous speed. So I try to keep up, and also
Thomas, there is a lot to come, no?
Yes.
You can tell everybody there is a lot of initiatives upcoming, no?
Yeah, absolutely, absolutely. So we are thinking about the new forms of teaching. And I think the online world is developing rapidly, and both of us sort of, Ale, you were there longer, I had to learn how to deal with social media, and I still sometimes stand there with open mouth and say, okay, this is working like that. And it's fantastic that we are seen on all the social media. So we are starting far off in Australia. And so we had also to deal with the time differences, speaking to everybody and begging people, so please could you start late in the afternoon, convince your team and so on. So
Thomas, now is 700 people connecting every second. So more you speak, more you are appealing, more people watching you. So you are a superstar.
It's probably your nice tie, Ale.
Okay. Also your tie is nice because it's I think it's the same brand.
Yes, yes, it is.
Okay, good.
Okay.
So I think we can go live now.
Yeah, I think we could start our trailer, which you have seen, and then we start the event from this studio. And both Ale and I will be in the virtual studio, and later on Amrita Sethi from New York will be joining us. So please enjoy the day. Tell all your friends, have it on in your endoscopy unit like CNN the entire day, and keep watching us.
See you later, guys.
So I think now our trailer comes. No trailer, you have seen this. So this is a journey through the entire world. And there are several reasons to start in Australia and Sydney. And I think the most important one is the presenter whom you will see. And it's also logical within the Commonwealth to have a moderator from London, Siwan Thomas-Gibson. So welcome, Siwan. And I think a few years back, we had a very nice British team moderating the Endo Club. And what I admired, so can we please see Siwan? What I really admired is that 5 British guys were coming. They were choking all the time. But when the lights were on, they were super professional and guiding us through the day. So I still admire that, and I tried to learn from that. And I like this bridge, but even more, I would like to see Siwan. Yeah, here you are. Good morning.
Morning.
It's 1 hour earlier. So Siwan, it's a great pleasure to hand over to you.
Thanks so much, Thomas. Well, it's an honour and a great privilege to be with you first thing this morning. And of course with Michael over in the glorious city of Sydney. How fantastic is this? This time last year, I was travelling. I was literally on the underground in London watching Michael live, but while I was travelling on the underground. It's just phenomenal. So, Michael, you're in Sydney. Good evening to you. It's great to see you. I think that's you behind the mask.
Yes, yeah, it is, yeah. Are we on air?
Yes, we are.
Oh, so perfect. Okay, so are we ready to go?
Yes, please. We can see, we think you're in the colon. Is that right?
Yes, we definitely are. So maybe Ollie, just tell us the case here.
This is a 74-year-old with a lesion in her proximal ascending colon, a 40-millimeter non-granular Paris 2A lesion. We're just reaching that area now.
Yeah, so I was caught up a bit in the traffic getting here, so we're just running a little bit behind schedule, but we have the lesion on view now, and I just soon would get very angry with me if I didn't straighten the scope before we did the resection. So you just saw it there for a moment. We're using the Fuji system, which has been working very well for us of recent times. This is in the transverse, actually. They said ascending, but I think it's transverse just by the way the colon's behaving. Sue, can we just have a bit of pressure mid-transverse?
So Michael, how was this lesion initially picked up? Was it a screening or a positive fit test or symptomatic?
So it was a positive fecal occult blood test, so one of the sort of Australian colorectal screening cancer programs, and then was picked up after a sort of a colonoscopy after that and referred to this centre.
Yeah. So this is the first time for us to see it. We saw the photos. So this is it's a non-granular lesion, sort of half the circumference. Unfortunately, just relax it. It's slightly obscured by the fluid. If we have trouble, we roll the patient always. But you can see it's an adenoma. You can see that clearly with the white light. And then if we scroll through the options, we can see on LCI and then on BLI, there's no disruption to pit or microvascular pattern. And it's a flat lesion. So I think we have in the literature box there, we have the paper from Bosco et al., which is from our center, just recently published in CGH, showing that the sensitivity for detecting cancer in flat lesions is better than 95%. It's quite different with nodular lesions, mixed nodular lesions or bulky lesions. So in a flat lesion, if you look carefully, the chance that you'll miss cancer in that large prospective study involving 2,500 cases is 6 in 1,000 cases. So it's really a very sensitive technique just to evaluate the lesion with high definition white light, BLI, or whatever your advanced imaging platform is. So we know that this lesion can be removed by EMR. And now, let's have the needle. So now we have the advance of hot versus cold. I think in the text box, you'll see also that in terms of cold, we've recently shown that for serrated lesions, the outcomes are the same. When we compared 400 cases against another 200 cases, historical cohort against a prospective, well, they're both prospective observational, but recurrence at 6 months was 5% and at 18 months was 2%. No difference, but bleeding was something like 5 or 6% versus 0%. So cold resection in the colon has no risk of bleeding. So virtually none. So what do we do? So to resect this lesion, so we're going to inject first. I think with any larger lesion, you should inject. So needle out. Just inject a drop. We just need to make sure that the catheter is primed. And we want to have the lesion, the target down at 6 o'clock. And so I start the injection before we stab the mucosa, inject. There we go. And inject. We were extramural for a moment because we didn't see any lifting. And so I pulled back a little bit. And now we're submucosal. Keep injecting, inject, inject, inject. Big injection.
So Michael, you've chosen to inject on the anal side, the distal side. How, I mean, our audience is enormous. I mean, Ale was telling us, I don't know if you heard at the beginning, we've already got about something like 55,000 people watching you this, no pressure. How do you choose where you put the first injection? There'll be a lot of different range of experience of people watching.
Yeah, look, cold snare. So you always make the first injection to facilitate access to the lesion. So you want to start in the most difficult area. So this is the area that's under the fluid. So I chose to start over there. And I want to lift the lesion up and out into the lumen. So essentially that's what I did. Yeah, so we're going to use this Fuji cold snare. It's only 7 millimeters, so it's a little smaller than the others. The features of the cold snare, they're all fairly similar. Snare wire diameter, this is 0.27, and they're up to 0.3 millimeter in size, 0.27 to 0.3 millimeter. And then they all have a stiff catheter to amputate against. And so What's the advantage of cold snare resection of adenomas? Well, no risk of bleeding. But what about the risk of recurrence? Well, there's no high quality RCT. We're about halfway through one. I think recurrence will be higher, but there's no bleeding. So we don't have to clip up this defect, I suppose. So if we open the snare, keep holding the scope always, Ollie. Open. So don't do this. Don't lay the snare down in the middle of the defect like that, right? You want to be very systematic about the way you perform the resection. So we want to start at one edge and we want to have a nice big margin of normal tissue. Open fully. Open always fully. Yeah. Okay, slowly close. So cold snare resection to resistance is quite different to hot snare, right? Because cold snare, we push down as firmly as we can and then we cut. So cut. Good. Open.
So Michael, I always talk to the fellows about the first piece that you take, really, it doesn't matter if it's quite small. It's starting off a plane in which you can then facilitate grasping
yes.
mucosa.
Yes. And maybe we've even close. We've over-injected here a bit, possibly. Cut. Open. And you just work sequentially along. So I go from the back here.
Why would over-injection be a problem?
Cut. Just makes too much tension in the submucosas and then the snare can't grab as well. Open, thanks. Probably not, but you can easily sort it instantaneously by just keeping working.
And so your injection fluid, you've got
see how I'm taking, so close. I'm taking lots of normal here, close, cut, open.
Michael, your injection fluid, are you using saline or gelifusing or what's in it? Adrenaline?
We're normally using gel, just because we showed in an RCT from about 2010 when we were both young that it was superior in terms of number of resections and speed of resection and so on. But you can see we've only done, even with this smaller 7mm snare, we've only done about 4 or 5 resections and we're about halfway done. And then if you wish, you can expand the defect with the fluid jet. So we won't put too much because the fluid will sink us. We'll end up doing underwater EMR, which we don't want to do.
Would this be suitable for underwater EMR?
Yeah, you could. We need an RCT against the other techniques, open things. So see this narrow isthmus of residual mucosa. So just hold the scope, Ollie. Yeah. This narrow isthmus of residual mucosa. So we want to push in. Keep holding, hold. And I'm working with the scope, not with the snare. So now I'm in a good position. Close slowly. Okay, and cut. Good, okay, so that's gone. And then we just keep working like that. So on, open. Across the front. Again, lots of normal tissue. And if you're in doubt, just excise. So close. Cut.
Michael, I think that's a really important message. Again, I think people are concerned for some reason about taking normal mucosa, but it's much better to take a really good wide margin. Yeah. Have you got adrenaline?
That's the beauty. Cut. Yeah.
Have you got
We've got adrenaline in the injectate. Yes, yeah. And the beauty, just to pick up on that point, the beauty of the cold snare resection is that you can make the margin as big as you like. So don't adapt the size of the resection to the size of the polyp. Take a huge margin for any polyp, even a 3mm polyp. Take out a 15 or 10mm defect. It doesn't impose any risk on the patient, but you can be sure you've got the whole lesion. So if in doubt, keep resecting. So we're going to keep going along like that. We use adrenaline in the injectate because it minimizes the oozing bleeding, open things, so it makes it easier to follow the plane.
So, Michael, I also
Here again.
use adrenaline. I know some of our colleagues don't. I like it because I think it also helps, as you say, keeps a dry field so you can see, particularly in the SSLs, which have subtle edges, you can see the edge much more clearly.
Yes, yeah. So now my colleague here, my expert colleague, Eric Lee, is going to take over from me, and I'm going to change rooms, and I'm going to demonstrate the technique of hot snare excision, and then we'll come back and look at Eric's handiwork.
Great. So you're going to leave Eric the difficult bit, Michael.
I was hoping you wouldn't notice.
We noticed.
He's very capable. So I'll see you next door.
Fantastic.
I won't be ticked, so you might want to re-inject, I suppose.
Yeah, inject the back.
Fantastic. So I don't know whether we're chatting to Michael on the run or you, Eric. We're next door by the looks of things. We've moved next door.
Tell us the case.
Yes, please. Have we got someone who can tell us the case?
So this is a 74-year-old gentleman who had a surveillance colonoscopy and essentially had this lesion detected. We're in the proximal ascending colon, and it's about a 40 to 50 millimeter Paris 2A granular lesion. The challenges have been his prep's not been fantastic, so we've had to do a lot of cleaning, and at the same time, he's got a lot of bowel spasm, so he's now had 20 milligrams of buscopan.
Thanks, Tim. So when I take the scope from the trainee, the first thing I always check is
it straight, which it's probably not.
Speak up. Speak up.
Is it straight?
Louder.
Is it straight?
Is it straight? Yes.
I heard, Michael, I heard.
No. Is it straight?
But we'll have to take your word for it. We'll have to take your word for it.
Yeah, it's not straight, right? I know he's a big fella, but it should be straight. Is that the lesion? So we need some busco.
He's had 20.
Yeah. So it's not, that's the lesion there,
Yeah.
is it? It's not so big. I apologise, but we haven't seen any of these. So, yeah, so you'd have a big loop here, buddy. Yeah, anyway. We can do it like this anyway, but let's have a look. You just have to turn down Eric's audio, please.
So, Michael, while you're trying to get a good view onto the lesion, joking aside, if you don't have some sort of scope guide imaging device, some guide, it can be difficult to establish whether you're looped or not. Do you want to tell us how you establish that?
Just really flat and spasmy.
Sorry? Yeah, so look, you can tell when you grab the scope whether it's straight or not, because when it exits the anus, it should just fall flat on the bed, just poof, and like a piece of licorice onto the bed. So if it doesn't do that, and you can feel the tension in the shaft of the scope. So pretty much, I think we should do a study with expert colonoscopists and just give them scopes to hold to see whether they're straight or bent, and you can tell. The expert can tell. It's immediately obvious to me. So we'll work from this position because it's not too bad.
Sorry, Michael, I was just going to add, you lose that one-to-one movement as you're
Exactly, yeah. And
scope.
Everything becomes just a little bit more difficult. Yeah, so here, now this is a little tricky. The lesion's not very big, but it's tricky because it's hidden behind a fold. It could be 2 lesions, do you think, or is it 1? Is it 2 or 1? You don't know.
It looks like 1.
Needle out, thanks. So what I'm going to do, because now this is, of course, goes to your question about where to inject. He needs a bit more stuff, eh? And some Zofran. So where to inject. So, and you had Busco? Yeah. So I need to inject behind to bring it up towards me. So I'm going to push the lesion down with the needle catheter, and then hopefully I pick up the fold on the other side, and then we inject. Yep. So we're not in. When you inject, there are 4 possible outcomes. Either you're extramural, you see nothing. You're intramural, fluid gushes out. You're intramucosal, in which case you get a bleb, or you're submucosal, which is where you want to be, and you get elevation. Inject. There we go. So that's submucosal. Hold it just slowly. So see, now what I do is I lift the lesion up into the lumen. It's impaled on the needle. So I lift it up into the lumen, inject, 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 inject. So it's interesting, isn't it? It's much more extensive than we appreciated. Okay, needle back. That's nice, very nice. Okay, good. So, and here we'll push it backwards. Okay, we're going to make a small injection at the front, needle out.
So, Michael, that really nicely demonstrates in the previous case you
Wait.
lifted on the anal side and that worked. This one really needed the lift on the oral side. If you'd lifted this on the anal side, it would have disappeared behind that fold, and you wouldn't be able to see it
needle
as well.
Okay, let's have the snare, thanks. Actually, do you have a 20 or just 15? You have a 20? No. Let's have 15, yeah.
So, Michael, do you have a problem with referrers? If referrers are sending you a case and they want to know whether it's going to lift or not, clearly, I hope the message has got to everyone now that we don't biopsy these lesions ahead of referring on. But do you have a problem if injected beforehand to assess its lifting status?
No, because even if they don't lift it, we actually published another paper in American Journal now, previously attempted lesions, and then we also published the data from the CAST study a couple of years ago. Even if they don't lift, they can still be removed so easily with a range of techniques. So no benign polyp should go to surgery. No benign polyp should ever go to surgery in 2020 or 2021. So I'll just take you through the technique here. So open fully. So we're in the right colon. So generally we use a 15 in the right colon. Now we're going to make sure we get a margin of normal. So I'm really going to push down and ensure that I have a margin of normal. Now I'm pushing down, close slowly. So we close to resistance, yep. And we feel resistance. Now I really like to do this myself because I can sense what's happening because I do this a couple of thousand times a year. So I know that the tissue should feel spongy within the snare, if you can see my hands, and I can move it back and forth. It's freely mobile relative to the colonic wall. And then to go through with fractionated current, generally it's just 1, 2, 3 through, or 1, 2 through. So
Michael,
maybe a bit more here.
I think I'm in your camp. I always close the snare myself. Many people don't, but I think for me, as you say, it's the feel. I always say it would be a bit like driving a car with one person on the accelerator and one person on the steering wheel.
Yes.
You know, I want to be in control of that. It's the feel.
So we enter, so next, take the excision where we entered the plane. So close, slow, close. And again, margins are big because we just, open, you were too slow closure. So, okay, hold on. Close. Oh, no. Open. So, sorry. Yeah, it's probably his breathing is part of the problem. Anthony, just hold the scope. There. Okay, that's better. Okay, slowly close. Close. Resistance, okay. All right, so we have some tissue at the back that we might not need, but let's check mobility. So mobility is fine. It feels spongy, so it should be fine. And when you hit the pedal the first time, do you see, Siwan, how it just, the snare cinches in immediately? So you know you're okay, right? You don't have the muscle. There's no invasive cancer. There's no fibrosis. So I think this is probably just a 2-piece excision.
So Michael, how do you think we teach that? Because you just said you do this a couple of thousand times a year. Teaching feel is really difficult. It's really difficult for people starting off doing this to know whether what they're feeling is the right thing?
I think you've got to do it a lot of times. So I suppose you've got to do it whenever you're doing polypectomy. You just grab the snare and handle it yourself. Now, there's a couple of interesting features here. So I left a little isthmus of tissue. So I'm going to take that, open thanks, although it's probably normal. Now it'll be slightly tricky because the tissue's anchored down. Could be a biopsy site, poorly targeted biopsy, it's normal tissue. But what I'll do is I'll do the suction pseudopolyp technique. So I'll aspirate the tissue into the channel. I'll pull the scope back a little bit and I just put tension on the tissue. I've got the snare right there. And then when I let go, it should be sitting up for me. So it'd be easy to grab. So I let go, there it is. Anthony, hold the scope. Open, so the snare's a bit big for this purpose, but still we can work with it. And we close a little, hold it, no too much. Open slide, hold. And I push the heel of the snare to the base there, close the resistance. Okay, now you don't need to watch what's happening. It's all about the feel. So when it's tricky, you know, a lot of this stuff we just do blind, pull the scope back a little bit. And then I just cut that off. Now I need the injector. Now we have some unstained areas in the submucosa here. Is anyone in the audience, is anyone worried about deep neural injury? Injury to the muscle layer? Soon?
So I don't know if anyone in the audience is. I'm not worried at the moment.
No, you're not because you're very experienced. So we see a lot of adipose. So if we're concerned, I think it's just adipose. We don't need to put the needle out. Don't put the needle out. We just irrigate. So we see nicely that, and now we can see the nice blue staining. So if there's muscle on view there, let's have some more busco, please. If there's muscle on view there, then it doesn't take up the blue dye. The fat doesn't take up the blue either, but irrigate. So stop. Okay, so that all looks good.
We're seeing that fat because you're in the right colon. You don't often see that in the left colon, but it can be a bit scary again if you see it for the first time.
So now I'm going to show you how to do the snare tip soft coagulation. So we just elevate the bed if we can, please. So we know in the randomized trial, the risk of bleeding was reduced from, the risk of recurrence was reduced from 21%, which is sort of real world data, I think, to 5%. And in the open label observational study that was just published in Gastro, it's online, like 1,600 patients, 800 with follow-up, recurrence was 1.6% or something. In my own personal practice, I never see recurrence, never. So this technique has revolutionized the approach, tip out. So the easiest way to do it, it's a stepping stone to ESD. So you put your left hip against the bed and we're going to use a blue pedal, 80 watts. This is a little bit tricky because tip out a bit. So I'm going to, and you just got to keep moving. So we need jaw lift or something.
Michael, very difficult when in some positions when they're breathing like this.
Yeah, so, but I don't adjust the position of the snare relative to the scope. So I'm working with the scope, like you do with APC.
Yeah.
And you just move sideways and then along. And I use the up-down wheel to sort of direct my scope along, rotate my body, and you can see the level of control I have, even with this guy. I mean, do you feel like you're on a ship at the moment, Siwan? If you watch this carefully, you'll feel like you're on a ship. You might have to take some seasickness medication.
But if I was in Sydney Harbour, I'd put up with it. So, Michael, would you do this with the cold EMR that you did in the other case? Or would you?
We don't know. We don't know. We think probably we will need to. Now, that was done in about a minute. So it's a very easy technique once you get the hang of it. And as I said, it's a good stepping stone to ESD because the movement is sort of circular. Now what I'm going to do is clip it up. So let's have the clips. So we know from,
which one? Liccardo.
We know from the RCT, there's 3 RCTs now, actually 4. The Fagan study, which didn't have so many big lesions, was the first, didn't show a benefit. Then Heiko's excellent study, the Clipper study, published in Gastro 2018, I think, showed bleeding risk reduced from 9 to 3%, but no benefit in the left colon. So it's only the right colon and not the transverse, just the right colon where the benefit exists. And then we have the Albanese study, which was 200 cases, and then our own study, which was presented at DDW recently, single center, 250 cases open, thanks. So where to start, where to put the first clip? Now, if I put the first clip, our results were just the same as the poll study. So there's no doubt it works. I was skeptical, but it does work. Even if you can't close the thing, if you partially close it, it just reduces the tension on the defect. And so I think it reduces the bleeding risk anyway because of the shearing forces for the sublethally injured vessels in the submucosa. The fluid's down here. So if I put the first clip here, don't close, the clip can fall onto the defect and make it more difficult. So although that's an easy target, open fully, it's much better for me to put the first clip on this left-hand side, which is more difficult. And so what I'm going to do is I'm going to go next door and finish off the cold excision, and I'll get Eric to come and do the clipping. Is that okay?
Michael, that's absolutely fine. I was going to chat.
No, that was a joke. That was a joke. rotate.
What I was going to say, Michael, is I'm sure he's finished the cold excision next door.
Hey?
Has he finished? He's finished next door. I don't know.
Okay.
So, in terms of clips,
rotate.
Whole range of clips.
Stop. You want it vertical, right? Yeah. I think you need, like, when it's a defect, you need a larger, strong clip. But if it's a linear incision like palm, you need a smaller, strong clip, like 11 millimeter or something. Close. Okay, just hold it. So we check because we can't see. So see, I aspirate gas. And I think we're okay, fire. Let's have another. Mightn't be exactly right, but we can get another on the basis of that. Just do something with this.
So, Michael, sometimes I find that
I
first
can use both. Perhaps some Loccardo clips. Yeah.
Which is...
Sorry, go on.
I was saying that sometimes the first clip, as you say, in this situation is difficult to place. But even if you can pinch just below the defect, it starts to pinch the edges together and can sometimes facilitate grasping the next piece of tissue. Clearly, it can go the other way as well.
Yeah. This is really terrible. Not so easy. Close. Okay.
Michael, dare I say, would
open.
Change sometimes be worth considering?
What's that?
Dare I ask whether patient position change, as you know, in the UK, we don't use a lot of propofol. So I would be thinking of flipping this patient, even just for the closure, might facilitate access.
Yeah.
More difficult under propofol.
Yeah, look, he's a super big guy. We could flip him, fire. It's not going to be the most elegant closure, so I apologise in advance. I'll get another one just over this left-hand side to see if I can nail it. But even partial closure works, so open things. Rotate, horizontal, back, keep going.
But Michael, I think the point I was making is that in clearly with propofol, whatever size, I mean, you know, small patients, it's easy to flip them. But if you've got a patient who's awake, even with very small polyps, changing the patient might actually facilitate access. It's a combination of
I think patient position change is really invaluable. but I can tell you culturally in Australia, we can't even do a digital rectal examination without giving the patient a general anaesthetic. Close slowly. That's also a joke. Fire. Okay, all right, so let's have a look. Heaven forbid we clipped some polyp in there. No, we didn't. So that's nice, that side now. Actually, we've done pretty well, actually. Let's have another Locato, I think.
So, Michael, are you going to tattoo either of these polyp sites to facilitate finding it? Particularly this one, quite tricky to find a follow-up, possibly.
It's not a bad idea. Certainly, if we were going to do a tattoo and we thought there was cancer, always do the tattoo first before you take biopsies. We know that from the excellent study from Lyon Moons that was published in Gastro not so long ago. The molecular signature within the tattoo, if you get a recurrent cancer, it's the same as the, so you need to, that's annoying, isn't it? So you need to make sure you don't contaminate the channel. So open a little bit, close, not too tight, open. Okay. You think it'll stay there? Rotate. This way. All right, stop. Okay. All right, so we just need one, we need 2 more clips on this thing. Just one here, open fully. Okay.
Michael, have you
normally want to just
reloadable clips?
Close. No. These are just all single use. So we're using the Fuji clip and also the Locato clip, alternate fire. So we'll need one more clip here.
Michael,
so we'll probably just put that one on.
Michael, we're being asked to draw things to a conclusion. I'll let you finish off.
Can we just,
fantastic demonstration.
Okay.
Do you want to just give any final points?
Duck next door, I think. What about if I duck next door? I just fire off this last clip, open, horizontal, quickly. Good, back. It's 1-to-1, right? These ones are 1-to-1. It's 1-to-1. So just keep going. That's it. Okay, good.
Nice.
Close. Fire. All right, I'm just going to duck next door. Hold on, don't pull it out. And we'll just see what Eric's done. I think the job's done, and then we can conclude.
Rothnet.
Beautiful job.
Eric, just quickly show us the beautiful.
Yes, I think
well done, buddy. Very nice. So I think, Siwan, so we've been able to show the different techniques in the evolving field of advanced endoscopic resection in the colon, cold EMR, which will certainly have a place for the management of adenomas, but up to what size we don't know. And definitely ulcerated lesions, and then hot excision for more difficult lesions, the existing standard, and against which the new techniques have to be compared. So on behalf of all the team, thank you for the opportunity. Thomas and Ali, best of luck. Siwan, great to talk to you again. I hope we can meet up again sometime. And all the very best to everyone from all of us here at Westmead.
Thanks so much to the entire team. Thanks. Fantastic.
Thank you.
Urbe wants to power your performance with a promising technique for submucosal dissection in ESD and POEM. Hybrid knife, together with the VIO 3 Precise mode. The Precise mode is provided by the VIO 3 workstation. Fully equipped, it is composed of the VIO 3, APC 3, and UrbeJet 2, and serves as the technology platform for standard and advanced endoscopy applications. Urbe's hybrid technology instruments and the FI-APC probes are established instruments in flexible endoscopy. Let us focus on the hybrid knife, which combines high-pressure water jet and electric current for all working steps during ESD and POEM. Especially dissecting the submucosa and coagulating vessels in this tissue layer are important steps for which the hybrid knife is ideally suited. The Precise mode, with its dynamic adjustment of the current curve, offers precise submucosal dissection and pronounced hemostasis with little thermal spread. Depending on the contact surface between tissue and electrode tip, VIO 3 pronounces either dissective or coagulative properties. Broad contact causes a rather coagulative effect. Only contact at the tip produces the dissective effect. Dr. Baina demonstrates the use of the Precise mode for submucosal dissection in a step-by-step video tutorial. Watch it on medical-videos.com. The clinical benefits of the Precise have already convinced many physicians. Dr. Honggang Yu states that Precise extends the utility of ESD knives. Follow his POEM procedure on medical-videos.com. In Professor Chacha's experience, Precise is a huge improvement which leads to fewer uses of the coag grasper. According to Dr. Elkoli's opinion, conventional coagulation modes are not satisfactory, as the carbonization contributes to loss of orientation. She thinks that Precise is a genius solution, as it preserves the orientation. Visit us on medical-video.com to learn how to dissect or coagulate vessels using the VIO 3 Precise settings with the hybrid knife.
Pooh, what a start. Exciting. Australia, London. And then we were calmed down a little bit by the video of one of our sponsors. So thank you very much to our sponsors. We are going westwards or north or whatsoever. The next city is Tokyo. And as a moderator, I'm very happy to welcome Mathieu Pioche from Lyon. You are a very critical center. I remember Thierry Ponchon always had the right questions. So welcome. We are happy that you are there. And please moderate the next two lectures from Japan.
Thank you very much. So it's a great honor to be here and to moderate my mentor, where I spent some time in Japan, only one day with Professor Inoue, but more time with Professor Yahagi. And the first lecture about the tunnel benefits in POEM procedure is presented by Professor Inoue, our guide for this wonderful technique. Thank you very much.
So thank you very much, Dr. Pioche, for your kind introduction for me. And first of all, I really appreciate Dr. Thomas Rösch and Dr. Alessandro Repici for your invitation. This very nice conference, UA, endoscopy on air. So my topic is a submucosal endoscopy. This is my COI. So submucosal endoscopy is the same to a third space endoscopy. So after install of the POEM procedure, we have several extension and applications. POEM itself, original procedure was developed in more than 100 years ago. Dr. Ernest Heller reported his myotomy 1913s. Wow. And now we can do it, his procedure by the endoscopically. So world first experience POEM was 2008. Please note the date of the procedure. blue arrow, and we place the anterior myotomy after mucosa injection, and now we dissect the mucosa and then get in a submucosal space, and they create a submucosal tunnel. The point is make a submucosal tunnel as a close to muscle layer surface. Now we are performing the myotomy, the world first case. Anterior myotomy was completed. Then after that, we close a mucosa entry using clips. So simple procedure. So volume swallow before and after procedure. First case was an easy case. We met a patient 8 years after procedure. So his satisfaction is 100%. He can eat well and gain weight 20 kilograms last 8 years. And no GERD symptom. This is an actual endoscopy at the time of 8 years after point procedure. So very slight A, grade A, like that. After this case, so far we performed more than 2,000 cases. And the indication is almost all the motility disorders of the esophagus that should be obstructed. Anyway, so diffuse esophageal spasm is one of the good indication of this procedure. So left volume demonstrate the stack of the volume in the middle esophagus. And after procedure, after point procedure, contrast media goes very smoothly. So in this case, we try to preserve the lower esophageal sphincter, and we did just the myotomy of the body of the esophagus. So this is the just before the treatment. The patient has some abnormal contractions. And this is a light after in a submucosal tunnel. We can preserve the last few centimeter, 2 centimeter of the lower esophageal sphincter. This narrow muscle band is a lower esophageal sphincter. So proximal part has already dissected. So in this case, 1 year after procedure, all the Eckert score improved and no symptom. So one of the offshoot of the poem is a poet, or endoscopic tumor resection. It's a totally same procedure to STAR procedure that was reported by the Chinese doctors. Same time, the different journal. So anyway, this is a case, tumor derived from the fourth low echoic layer. The CAT scan demonstrate the tumor in between the trachea and the descending aorta. So in this case, the same, we create a submucosal tunnel. And then in a submucosal space, we can identify the submucosal tumor. And then we are dissected from the muscle layer. And then after total mobilization of the tumor, we take out the specimen through the patient mouth. So anyway, after resection, there was a muscle defect, and you can see a membranous portion of the trachea. Anyway, so right after procedure, just close a mucosa entry using clips. That's enough. So my colleague, Onimaru Sensei, so he summarized our data. So based on our experience, less than 4 centimeter tumor is the best indication of the procedure. Zhou's group, Chinese doctors, also reported a similar results. So yes, so extensive cases, the tumor size. This is the Philip Chiu also reported. Less than 4 centimeter tumor is the indication of this procedure. So next, So another important indication of a poem procedure, it's a gastroparesis. So like this illustration, we generally approach the greater curve side and cut the pylorus muscle. So one of the first case of the G poem, gastric poem, was done in Johns Hopkins 2013. So I did it on the, together with Moen Kashyap and Dr. Stavropoulos. So Dr. Moen Kashyap summarized the data, reported the first case, first experience, and they summarized lots of data like this. So success rate, clinical response rate was 86%. So this is our case. The Japanese patient, the patient has a very tight pylorus ring before procedure. So in this case, we approach the greater curve and create a submucosal tunnel. Now we dissecting the pylorus muscle. And then, so you can, center of the image, you can recognize the very thin duodenal muscle layer. So myotomy of the pylorus ring completed. We confirm it using double scope technique in this case as well. Anyway, after that, we just close the mucosal entry. So next good application of the poem procedure is a Zenker diverticulum. So this is a volume swallow. You can see the Zenker, typical Zenker image like this beforehand. So so this is an endoscopic view. This is exactly this is a case of a Kilian Janison. But anyway, so we place the mucosal injection light on the septum mucosa. And we place a mucosal incision at the entrance into the tunnel. And then after that, we try to cut the cricopharyngeal muscle. So at this moment, so we try to preserve the mucosal layer as much as possible. And then dissect the only muscle layer until to reach the mediastinum. So after total dissection of the cricopharyngeal, so we close a mucosal defect using clips. So like after procedure, so this is several months after procedure. Yes, septum was totally controlled well. So right after, so this is the volume swallower. We cannot observe the diverticulum. So next application of the technique of our submucosal endoscopy is a D poem. So this is a poem for esophageal diverticulum. So in this case, we try to resect the diverticulum endoscopically. Okay. Okay, so this is a volume swallower. You can see epiphrenic diverticulum. Then, of course, the outlet obstruction exists. So anyway, so in this case of high resolution manometry, demonstrate normal peristalsis of the esophageal body. Anyway, so yes. So first we create a submucosal tunnel, a 5 centimeter proximal from the diverticulum. And then we create a submucosal tunnel close to muscle layer. And then we reach the diverticulum, and we are trying to dissect our diverticulum mucosal pocket. So this is the submucosal tunnel. Now we are trying to get into the behind the mucosa of the diverticulum. So mediastinum is open. Okay, so after that, after mobilization, after dissection of the back side of the mucosa, using another scope, we try to pull the mucosal layer into the esophageal lumen, inverted. Then we continue to dissect behind, like this way. So with the traction of the mucosal layer, we can keep a good tension to the submucosal tissue and mobilized from the background mediastinum. Anyway, so after that, so we close a muscle defect using a suturing device. This is a closure of the muscle layer using a needle holder, direct suturing of the muscle layer. Like this way. So after that, inverted mucosal layer was dissected using a conventional snare. After that, we fixed it using the regular clips. So right side, you can see your specimen. So after procedure, diverticulum gone. So it's a relative smooth passage of the contrast media. Endoscopy demonstrated a nice healing. Yes, diverticulum. Okay, finally, I'd like to briefly mention about another extension of the submucosal endoscopy. So in order to solve the potential problem of the poem, postponed GERD, so we are doing the dual anterior partial fundoplication using nodes technique, a flexible endoscope. So far, we did this procedure for our endoscope fundoplication, did it in 44 cases so far. Toshimori sensei summarized the data. Anyway, so creates a submucosal tunnel in the anterior wall of the esophagus, and then we catch the anterior wall of the stomach, and then fix it to our abdominal esophagus. We use a Goto sensei's hand suturing machine. Anyway, so in the submucosal tunnel, now we are dissecting the peritoneum. Behind, you can see back side of the left liver. Open up the peritoneum and getting an abdominal cavity. So keeps a J turn, and then now we are placing piercing the needle through the gastric wall. So intragastric monitor endoscopy demonstrate the needle is coming into the stomach inside and then goes out. This is a proximal fixation, the V-lock to our diaphragmatic cruise. Anyway, so putting the V-lock, we can create the partial fundoplication like this. This is a data, 43 cases, so technical success rate 100%, and the pH improved after procedure. So we think the application POEF is like this way, a little bit mild fundoplication than dull fundoplication, almost same. So thank you very much, everybody. So I demonstrated the application of a submucosal endoscopy and the technical tips. Thank you very much for your kind attention.
Thank you very much, Professor Inoue. It's fascinating, and I'm fond of all your innovations since years, and I'm always impressed. tunnel is becoming the beginning of everything when we see your different techniques. For the diverticulum in the esophagus, for example, do you think that the most important part is to resect the diverticula or to do a myotomy under to remove the relief? You demonstrated a very beautiful technique to remove all the mucosa and close the defect, but do you add a myotomy under to remove the relief at the same time?
Okay, thank you very much. It's a very important question. So in this case, demonstrated case, we endoscopically resect the diverticulum, but just performing the septectomy, that is also effective. So if it depends. And also this case was a high resolution manometry demonstrated outlet obstruction. Then we add the myotomy of the LES. I don't think all the case of the diverticulum should be resected. So I don't think so. But in this case, we did it. So reason why is a surgical approach. Thoracoscopic approach is to resect the diverticulum itself. So that's a reason why we did it. Same to our thoracoscopic approach, but I think not always necessary to resect the diverticulum itself.
Thank you very much. It's fascinating and amazing, but we should go on and ask to Professor Yahagi to talk about ESD and update about submucosal injection. Dear Sensei, it's for you.
Oh, thank you very much for your kind introduction. And it is my great honor and pleasure for me to participate in this wonderful event again. Well, I'm going to talk about update for injection solution during endoscopic resection. Oh, I'm sorry, it's stuck. Okay. There are some important requirements for good injection solution. Basically, it should create good elevation and it should long lasting. And of course, if there is some tissue damage, it is not good for tissue resection. Therefore, the solution should not have any tissue damage. And it must be easy to handle and with reasonable costs. All these requirements are very important when we conduct actual human procedures. At least 20 years ago, there was no specific injection solution for endoscopic resection, even for ESD. Therefore, we checked the lifting ability and long-lasting ability, recruiting many commercially available injection solutions, including normal saline and sodium hyaluronate. As you can see here, normal saline can create relatively lower fluid cushion and last very fast. And most of the hypertonic solutions, such as 3.8% sodium chloride or 20% dextrose solution or glycerol solution, can create a little bit higher protrusion and last relatively fast. On the contrast, two of the sodium hyaluronate solution, which is Alts and Sveni, this is a commercial name. Both of them are 1% hyaluronic acid solution, can create the highest protrusion and last very long. Of course, the cost of hyaluronic acid solution was very expensive, and also it was very difficult to inject 1% sodium hyaluronate solution through the very narrow lumen of the injection needle. That's why we usually dilute sodium hyaluronate with normal saline, then used for ESD procedure. But we thought that it is also very important that solution doesn't create any tissue damage. That's why we conducted the animal study using most of hypertonic solution as well as glycerol solution and sodium hyaluronate solutions. And as you can see here, surprisingly, most of the hypertonic solution caused tissue damage. For example, 50% glucose solution, which is 10 times higher osmolarity than normal saline, caused some full layer tissue damage 1 day after injection. That was surprising situation. And even 20% dextrose solution caused a gastric erosion. That's why we decided not to use simple hypertonic solution anymore. But different from those hypertonic solution, only glycerol solution didn't cause any tissue damage because main component of glycerol solution is 10% glycerin, 5% fructose, and 0.9% sodium chloride. And usually 10% glycerin freely permeates through the cell membrane. That's why it doesn't cause any tissue damage. Therefore, I believe that glycerol solution is ideal solution for simple endoscopic resection procedure. And this is very cheap solution, which costs only 200 Japanese yen, which is $2 or less than €2 for a 200 milliliter package. Unfortunately, this solution is only commercially available in our country. Therefore, in case of demanding to use this solution in European countries or United States, you should ask your pharmacist to create this solution at your own pharmacy. But the formula is very simple, which is 10% glycerin, 5% fructose, and 0.9% sodium chloride. This was originally made for the treatment of brain edema in case of cerebral infarction, but currently we are actively using this solution for the purpose of submucosal injection when we perform endoscopic resection, including ESD. But in some difficult cases, we need more long-lasting solutions such as sodium hyaluronate. Previous original solution was 1%, which was very difficult to inject through the injection needle. That's why Professor Yamamoto designed a much diluted sodium hyaluronate, which is 0.4% sodium hyaluronate. This is already commercially available, and it is a little bit expensive, but very effective. But unfortunately, there is some data that sodium hyaluronate promotes the proliferation of cancer cells. That's why other Japanese company developed another viscous agent, which is sodium alginate. Sodium alginate is derived from giant kelp, and it is basically cheap solution. And of course, because of the viscous nature, it can create a higher protrusion, same as sodium hyaluronate. And we checked the efficacy and feasibility of this solution for endoscopic resection. And we found that it is almost equal effect to hyaluronic acid solution. That's why currently we are also using this solution for daily practice. And there is a very important technical tip when we use those kind of solution for our daily practice. In order to visualize the submucosal layer, I always include small amount of indigo carmine for both solutions. But I always intentionally make viscous solution much darker because we can easily recognize the injected solution just looking at the color of the injected area. And there is another important technical tip. Before using viscous agents such as hyaluronic acid solution or sodium alginate solution, we should open the submucosal space and visualize the narrowed area. Then we can give additional fluid cushion using viscous agent directly to the scalp area. This is the most effective way to do nice submucosal injection. I would like to show you some of the example. This is very much challenging case because this flat lesion located very close to the major papilla in the duodenum. Now we can see the major papilla, and I already injected glycerol solution. And I prefer to perform duodenal ESD using water pressure method. That's why I immersed the entire lesion within the normal cell line and conducted mucosal incision and submucosal dissection. Usually, we can open the submucosal space by applying water pressure through the endoscope. But in this particular case, because of the undulation of the duodenal lumen, it was impossible to open the submucosal space. That's why I injected sodium alginate, which was colored relatively dark blue color with indigo carmine. Then we can nicely open the submucosal space, and we can easily recognize the right dissection plane. As a result, following submucosal dissection becomes more safe and more easy. Now we can see the blue colored submucosal layer. This is completely safe situation. I would like to show you another case, which is a recurrent case after a conventional EM procedure at the transverse colon. Now you can see the scar-formed laterally spreading tumor. I already opened the submucosal space, but because of the severe fibrosis, I couldn't conduct submucosal dissection furthermore in this situation. That's why I injected blue-colored sodium alginate directly to the scalp layer. Then we could easily recognize the remaining submucosal layer. As a result, I could dissect the scarred tissue very safe in a safe manner. Now you can see blue-colored submucosal layer, and I could easily dissect this severely scarred area. This is the one of the very important technical tips when we conduct the very difficult ESD procedure. Well, once more again, this is important technical tip. We should visualize the submucosal layer before injecting viscous agent. Then we should inject viscous agent only the point which we want to lift up, where there is lots of fibrosis or narrowed lumen. Well, there are another commercially available solutions in the Western countries. Unfortunately, most of solutions which I showed you are not commercially available in the Western countries, but you can use gel fusion, which is 4% fluid gelatin. This is also relatively cheap solution and worked very well. And the Australian group conducted large-scale randomized control study and proved the efficacy of this solution. They can easily remove the relatively large flat lesion in the colon using this solution. I think this is a good alternative of the glycerol solution in the Western countries. And also Volven, which is 6% hydroxyethyl starch, is also a good solution for the submucosal injection in the Western countries. American group also conducted control study and proved the efficacy of this solution. you can use this solution for both EMR and ESD. And there are some new injection material coming from industry. Eleview or Olyse gel and Lift Up are very promising injection gels. Regarding Eleview, Italian company developed this one, and this is a copolymer and creating a molecular net that prevents water and fluid migration by binding between a biocompatible polymer and the polar group of physiological biopolymer in GI tract. That means fluid cushion doesn't leak out from the incised area, stays longer until the end of the procedure. This is a wonderful situation. Of course, the price is a little bit expensive, but we can complete the procedure with much less volume of this solution. And Olyse gel is a new solution coming from Boston Scientific, which is also synthesized polymer and stays longer. And the viscosity of this solution is 3 times higher than the Eleview solution, but the passage through the injection needle is nearly the same. That means it is easy to use and stays longer. And it is also very effective for standard EMR and also ESD. And Lift Up is the most unique solution which was developed by Obesco. This is thermally sensitive copolymer made from ethylene oxide and polypropylene oxide. And once it goes into the human body, with the temperature of the human body, it's generated, then it stays longer. That means we can keep the nice submucosal fluid cushion until the end of the procedure. And German group already conducted comparative study between Hespan and Lift Up and normal saline and proved that they can complete the procedure with much less volume using this solution. This is promising technique solution, but unfortunately, I don't have enough experience using this solution because it's not commercially available in our country. Well, recently, Portuguese guy whose name is Rui Castro published a nice summarized paper regarding injection solution. And as you can see here, normal saline and dextrose water is very cheap, but lasts relatively fast. And viscous agents such as gelatin or starch can stay a little bit longer. And another new synthetic polymer stays much longer, but it's very expensive. Therefore, you should select the appropriate solution depending on the situation. Usually, normal saline is still good enough for small-sized EMR, and long-lasting solutions such as gelatin or starch solution may be beneficial for piecemeal EMR. And much long-lasting solutions are helpful for safe and faster ESD, but of course, balance between the cost and the benefit is very important for everybody. Thank you very much for your kind attention.
Thank you very much, Professor Yahagi. Sorry, we have no time for question, unfortunately, but thank you very much for this great overview.
Thank you very much.
So thanks to another major sponsor, Olympus, and also, of course, thank you to the Japanese masters from whom we have all learned of. We are moving on. Next station is Hong Kong, and there are a lot of innovations going on. And who could be better prepared to moderate and comment than Stefan Seewald from Zurich? Hi, Stefan. Good morning.
Good morning.
So I hand the scenery over to you and to our nice and friendly and innovative colleagues in Hong Kong.
Hello, James. Welcome.
Hi.
Hello, Stefan.
Hey, Stefan. I have with me Shannon. We have two cases to show. Shannon will tell you a little bit about the first case.
Great.
So the first case, we're going to show a robotic assisted ESD for a rectal lateral spreading tumor. So it was an incidental finding, and colonoscopy showed a 2 centimeter LST of a granular type and a nodular mixed type in the Paris classification of type 0, 2A, and 1S, and a JNET classification of 2A. Biopsy of the polyp was a tubular adenoma, suspicious of focal high-grade dysplasia. So
Hi,
today,
hello.
Philip will do a robotic.
So thank you very much for joining our session in Hong Kong at the Chinese University. So I'm Philip Chiu. I'm now working with Dr. Honchi on a case of lateral spreading tumor in the rectum. And so today we are using the latest system of the EndoMaster robotic system for performance of a ESD for treatment of this lesion. So now actually we are calibrating the system because this system required the 2 robot arms passing through the endoscope. And you can see here that we are actually doing some jiggling action in order to relax the wire before we actually be able to control the robot arm and start the procedure. So, the patient is now lying in the lateral position, and the lesion is 10 centimeter from the anal verge. So now I'm trying to readjust the robot arm so that we'll be able to make a good control. So it would take some time for us to calibrate before we start the procedure. And this patient is now under monitor anesthetic care. So in the control of this arm, actually, we have to adjust the leg strip so that it becomes a V in the action. Okay, so now I think it's all right. So we'll start the procedure. So you can see I'm going to lift up the lesion by the left arm. So before that, I actually can just open a little bit more of the mucosa, like here. So I'm using the right arm for the dissection. And the gas insufficient is actually using the CO2. And so we are trying to mark around the lesion. So down a bit the scope. Yes, thank you very much. And then I can actually see the mucosa here as a margin. And then I use the cautery knife to open up. And then afterwards, I'm going to shift to the other side. So, and perhaps we could, in fact, just turn a little bit over the right side. Yes. Okay. And down a little bit. And then I'm trying to use the forceps to grasp the mucosa and lift up. So now like that, and expose at the submucosa. And we need to do some circumferential mucosal incision before we can proceed. So let's change to the right side a little bit. Yes, thank you very much. Yeah, I agree. So maybe we should change a little bit to the left side, or we should actually change the robot arm down a little bit. Yes, please wait. So we can actually do a little bit more over here, but can you down scope? Yes, thank you.
So the robotic system is introduced through a therapeutic colonoscope, and you have the 2 robotic arms and an additional working channel.
This is a two-man technique. There's an endoscopist holding the end of a scope, and that the second endoscopist, that is Philip.
So I guess we probably need to
operating at a distance away.
Perhaps over here, you can see. Okay, thank you.
So this is a prototype endoscope system being
I guess we
evaluated.
need to change the right robotic arm, calibrate a little bit. Okay, so let's try and recalibrate the right arm. I think we should, recalibrate the right arm, because sometimes when we are operating, when the arm is not in a good position, then we can recalibrate. So at this moment, the computer is detecting the right arm. And a lot of time, the scope is in fact a newly designed endoscope. So for the performance of this Endomaster robotic ESD. So the right arm is attached to an electrocautery, and so we can dissect around. And this system can perform both submucosal dissection and also circumferential mucosal incision. And the injection solution that we usually use is the all-right gel. And it has a high molecular weight so that it will stay in the submucosa for a longer period of time.
And another question, this system is especially designed for the colon because you use the 1 robotic arm for lifting up the lesion and the second then for cutting.
Yes, the system is designed for colonoscopy. So the scope itself is, the length of the scope is designed for colonoscopy, and the handle of the colon is actually next to the machine. And the assistant, who is Dr. Yip now, is just holding the scope, but not the knots of the patient. So the knots of the scope is controlled by the assistant is just controlling the camera end of the scope. And this, because as Professor Lau has mentioned, it's just a prototype. So then Philip decided that we start with colonic ESD first. So the idea of this robotic system is that the left arm lifts up the lesion for tension, and the right arm cut with at the 6 o'clock region. So now, since Philip is calibrating the arm, sometimes it takes a little bit of time. So can we share the second case? So the second case is an esophageal ESD that is prepared by...
Good afternoon. Today, I would like to share a case of esophageal ESD. I'm Dr. Honchi from... We have a 74-year-old gentleman with an incidental finding of multiple esophageal dysplasia, characterized by a brownish discolored area with abnormal IPCL, Lugol's iodine unstained area associated with pink color sign, spanning a total of 5 cm in length in more than 75% circumference. Biopsies showed at least moderate dysplasia. During the ESD, these were the equipment that we used. Due to limitation of time, we had to fast forward the procedure in 2 times speed. Upon scope insertion, using the new generation narrowband imaging system, you can see clearly a brownish demarcated area with abnormal IPCL. So the marking was performed using this new MT knife with a bipolar device. And this is what happens after marking. You can see very extensive Lugol's unstained area located more than 5 centimeters in length. So this is the distal lesion. This is where the proximal lesion is located, occupying more than 2/3 of the circumference. So we proceeded to ESD. So initial mucosal cutting after injection was performed using this new MT bipolar knife. So this bipolar knife has a ceramic tip, also with a needle type of energy device. And you can see how efficient it is to cut through the mucosal incision. So we did it very carefully so that we are able to resect all the dysplastic lesion while preserving as much mucosa as possible due to the more than 2/3 circumference involvement. So this is the mucosal incision part until we are able to obtain a half circumferential incision of the most distal lesion, followed by trimming so that we can get to the depth where the muscularis propria is located. And then we can do on the other side the mucosal incision. So because of time, I already showed this is already completed circumferential incision and trimming. So this is the distal lesion, the final part of the lesion, where the entire distal lesion is now being resected after this strip of mucosa is being resected. Now this is the second and the third lesion being excised. They are excised together because they are located in very close proximity, and the primary goal here is to preserve a strip of mucosa bridge so that we can reserve as much mucosa as possible. So for the sake of live demonstration, so we have already changed to another type of knife. This is also a needle type knife from the Olympus company, the dual knife. So now we are cutting towards the distal side where the previous lesion was located. And then we go back to the proximal side where we can now connect the mucosal incision towards the distal incision that we made just now, followed by trimming of the mucosa. So now this is the second lesion that I mentioned. So after the mucosal incision on that particular side, we proceeded to excision of this second lesion very, very close to the mucosal incision I made just now. So this is a small lesion, but yet it's close to the third lesion that we are going to resect later. So anyway, we had to resect this small piece of dysplastic lesion as well. So a mucosal bridge is preserved, you can see on the screen of the left side, in order to avoid post-ESD stricture. So just an ESD of this very, very small lesion. So the beauty of ESD is that you can do very, very precise incision and dissection so that you can avoid resecting unwanted normal mucosa. So after resecting the lesion, second lesion, then we proceed to the mucosal incision of the third lesion on the other side of the mucosa, again taking care to preserve as much normal mucosal bridge as possible. You can see I'm going quite close to the marking that we make, so that as you can see here, when the lateral incision has been completed, we are preserving as much bridge as possible. So now we go back to the proximal incision on the top. So this is a new mode of the EVIS X1. So you can see that this is the RDI mode, where they utilize the new amber light so that it will become slightly yellowish, but bleeding can be precisely identified, as you can see here, and then coagulated accordingly to achieve a as much bloodless procedure as possible. So now this is the procedure when we complete the proximal mucosal incision to connect the two side incision. So now you can see the last bit of the proximal mucosal incision being completed after incising, apart from the mucosa, the muscularis mucosae as well. So you will see muscle fibers that are not circular in shape and orientation. So this should not be mistaken as the muscularis propria. Like here you can see. So these are the muscularis mucosae, which should be dissected open until the transparent and mucosal plane is being identified. And so more of dissection is made on the proximal side in the submucosa, and also trimming on the side. until you can see quite a nice submucosal flap that's being exposed. So at this juncture, we decided that that we will use a two-clip traction technique because of the wide circumference of excision. So we had to do with two clips so that we can efficiently retract the lesion and countertract the lesion for a very easy dissection subsequently, where you can see. So two clips has been applied with a line on the proximal side of the mucosa. And then after lifting it up and giving tension on the oral side of the string, you can see that the submucosal plane is fully exposed. And we are able to identify the submucosal plane nicely with very good countertraction. And you can also see the muscularis propria layer now. So we're staying on the transparent plane in the lower third of the submucosal layer. So we are not going on the top of the submucosal layer, but staying slightly close to the muscularis propria to get a nice specimen. And through the procedure, there's a large penetrating vessels which bled. So again, we change to the RDI mode, and then we can see the bleeding quite easily. So this time a coagulation forceps is applied. So the initial application failed to control the exact site of bleeding. You can see bleeding again. So some manipulation, now we can see that the bleeding has been completely controlled. So this is towards the last bit of the submucosal dissection. Again, with the aid of the clip traction by the use of empty clips, you can see that the submucosal plane is very, very nicely highlighted and the muscularis propria clearly seen. So all we need to do is to dissect this almost transparent plane of submucosa until we are getting to the distal part of the incision, and then just complete the dissection. So this is almost towards the last part of the mucosal, submucosal dissection. And this is the last bit. So there's again a small penetrating submucosal vessel, very slow oozing but easily controlled with the use of this ESD knife. And final submucosal dissection is completed. Now the lesion has been completely excised. This was the post-ESD defect in the proximal side, in the middle part where a slim mucosal bridge is being preserved, and finally the distal part, again a near circumferential resection completed, and these were the specimens being pinned on a foam board. After the ESD, the patient was put on 8-week course of systemic steroid as a prevention of ESD stricture, and a repeat endoscopy was arranged 4 weeks later. Pathology showed high-grade dysplasia with clear margins except for the middle one, which only showed a focally involved low-grade dysplasia. Thank you very much. Good afternoon. Today I will...
Hello, okay. I think you are back. So now we are starting to have the submucosal dissection here. So now we have already opened up a lot of the mucosa. So generally speaking, we don't need to open up the whole mucosa. And you can see that this is the lifting of the left arm. This blood vessel, which I use a coagulation mode to stop the bleeding, and then cuts. And then you can see the whitish part is the muscle layer. So now we are dissecting over the submucosa like that. So the exposure of the lesion now is quite good. So we can see very clearly the submucosa, and then we continue the dissection like that. So the lifting or the retraction force can actually be multi-directional. So I can change at all time in the different direction of the retraction. So I can lift it up, I can twist it to the other direction. And you can see here now we are dissecting at the base and the submucosa, and with a good exposure of the blood vessel. So working very well here. And so for this robotic ESD, we need a good space for the dissection and within the lumen. So for the exposure as well. But it's very different from the conventional ESD, which you have just seen the video. And so we are not going really close to the submucosa by the camera and lifting by the cap, but we actually use the arm to lift up. So, and then now I'm trying to re-grasp and maybe to a little bit over the right side more than the left. Yes, okay, thank you. And so sometimes we do it in the general anesthesia, so the patient may be a little bit more stable, but it can be done also by monitor anesthetic care.
I think the concept looks very impressive.
So now we are seeing the submucosa, and we are trying to dissect at the submucosa at the edge of the tumor.
Currently, this is a prototype system. I think the
so we are not only lifting up, but we can actually push away the lesion, and we can, after pushing away, move it to the left or the right side to allow us to have a good dissection like that. So I'm actually pulling the mucosa, so to favor the dissection over the right robot arm.
It looks very impressive how Philip does
usually we can control by the coagulation mode.
We have a question. Is this system also?
We also, you can see that we also have a water.
If you have a perforation in the colon,
now we have to reposition the robot arm and continue dissection probably over the mucosa, open a little bit more.
There was a perforation,
so the robot arm can actually be extended.
This is a 29 days.
So that we can continue the dissection.
Also for closing perforations.
And so if any unclear of the lens, I can actually use water to clear it.
I'm not sure if I understand your question. We've not had a perforation in 20, this is our 29th case.
So maybe
I think the beauty of the system is that it enables you to operate with two arms. But unfortunately, the arm's a little bulky at the moment.
Way to retract or expose
it needs to be further refined, the system.
Rectal wall.
No, my comment was that I think you can also use the system if you have a perforation to close perforations, because I think it looks very impressive how Philip lifts up the mucosal flap and has perfect access to the submucosa.
So pay attention to the tumor margin is important.
Unfortunately, we've not seen a perforation, so we really do not know. So right now, the system doesn't have a suturing capability. We are limited by the design of the two arms.
So even, you know, during the procedure, we may use the accessory channel to insert a little bit more of the instrument.
I think it's a good idea that we will develop more accessories. So
you can see
that
we are now
so the left arm is always the border. The right arm is a diathermy. So
we have to be very careful not to cut into the border of
like
this
needle driver and things, because the whole concept is a little bit like surgery.
So maybe it's good enough, so we can come back.
So hopefully we will be able to develop more accessories, as you mentioned, to close defects.
And then we can grasp over here.
Full thickness resection maybe in the future.
For the audience, I think it's interesting. Philip published a paper with preliminary data.
Now we can see again the submucosa here.
And correct, but that was an earlier system. This is meant to be an improvement already, but and obviously things will evolve in future. And
so if there's any blood vessel, we'll try to stop the bleeding before we cut. Here, like here, using a coagulation mode.
We have not shown the console. Philip is actually sitting at a distance away from the patients. In the console, the control actually like the surgical Da Vinci system that we have is actually very intuitive.
Jim, what do you think? What is the learning curve? How many procedures you have to do to be fit for the procedure?
I think learning is not much of a problem. I think sometimes we have it's the instrumentation that sometimes is limiting. It's a wire system. We had a bit of hiccup. There was some initial problem with the arm. So I think in the group, only Philip has enough experience on the system. But I think it's like the idea is like the surgical Da Vinci system, that learning should be intuitive.
Yeah. We were very impressed of your procedures, also the procedure from Hon. And what I want to mention is that Philip last year got one of the Spirit of Hong Kong Awards for innovation for searching in the system. And congratulations to Philip and your team to the outstanding presentations, and good luck for the further research.
Okay, thank you very much. We're coming to an end. Okay.
For years, clips help the physicians to do a lot of treatment, including mucosal defects and gastrointestinal bleeding due by ulcers or any kind of arterial lesions. However, with the time, we saw a lot of limitations of the design of the clips. That's why nowadays we have new kind of therapeutic clips. One of these full circumferential tissue closure is the called padlock clip defect closure system that facilitates fast and effective while still maintaining blood flow to promote healing. I believe that the most important system features of padlock clip is that it's a preloaded self-grasping clip designed to encircle, lift, close, and potentially the healing of tissue defect. Quick and easy attachment to the outside of the endoscope, and it's very intuitive push of the thumb deployment. Finally, other big advantage over other similar clips is the diameter of the clip have less diameter, and second, the cost.
So welcome back to our studio, and thank you to Steris, US Endoscopy, another sponsor of our event. You have seen interesting innovations. So we are behind the surgeons with robotics, and I'm very curious to see what will happen. Before we move on to our next center in Shanghai, we are very happy to have the welcome address of the president of the Chinese Society of Digestive Endoscopy.
Dear Professor Repso and Professor Rösch, dear professors from all the world, I'm president of the Chinese Society of Digestive Endoscopy Auditor. CSDE, I'm Dr. Ling Hu. I'm very honored to be able to attend the Endoscopy on Air conference. The first Endoscopy on Air brought together exciting digestive endoscopists from 12 cities in the 5 continents to discuss and show the diagnosis, treatment, development, and the future of digestive disease last year. The live stream have attended more than 20,000 views online in China. The EOA conference has been upgraded again this year, which brings together outstanding endoscopy physicians from 90 cities in 5 continents. This endoscopic live stream delivers the fantastic lectures and the lab cases, including the latest innovation in the fields of the digestive endoscopy and the most exciting topics. I believe this live stream will play an important role to promoting the development and the application of the digestive endoscopic diagnosis and treatment technology in the world. In recent years, the field of digestive endoscopy has entered the most rapid development period, with various new technologies and new concepts. For example, the digestive endoscopic super-minimal invasive surgery SIMS, SMIS, that is chronic disease while perceiving the integration of human organ anatomy to stand of a serious surgical operation. The use just the method as MR ESD tunnel technique, for example. And the application of AI in digestive endoscopy is becoming deeper and deeper, and maltreatment difficulties have been gradually solved by the new technologies. Finally, on behalf of Chinese Society of Digestive Endoscopy Origin, I wish this conference a complete success. Thank you very much.
So thank you very much, Professor Ling Hu, for your nice welcome address. And now we move to the beautiful city of Shanghai. And it's very logical to couple it with a moderator from a beautiful European city, Barcelona. So we welcome Maria Pellice, one of the most prominent young endoscopists in Europe. Maria, welcome. And I hand it over to you for the moderation of the Shanghai session. A lot of submucosal tumors, so I'm curious.
So hello, good morning to everybody. It's a big pleasure to be here in this event. And really waiting for these cases from Shanghai that I am sure will be very, very interesting. Hello, Professor Zhu. I'm looking forward to see you in action and explaining interesting things.
I would like it to. Yeah. Chiu, would you please yes?
Sure. This is a 50-year-old lady admitted to our hospital for two submucosal tumors, one in the GE junction and the other is in the gastric body, the posterior wall. So her past medical history was unremarkable. Today, Dr. Zhu plans to perform a full thickness resection of the lesion in the gastric body. And he has finished the circumcision and leaves the best part and the most exciting part for EUA audience.
I would like to use the hyperknife eye type. Hyperknife. What I used was from the location of this. As a result, hyperknife.
The volume is not very good for Dr. Zhu. Can you please?
For the live demo, I have finished because you see, from the tumor. Oh, but
I'm sorry, we'll change the microphone.
Thank you, that's perfect. But we can see very well the images, so
this eye type from hyperknife from early Germany. So the big advantage of the hyperknife is it can inject during the procedures. So now I inject the solution into the submucosal layer and dissect the lesion around the capsule of the lesion. The solution we always use is the saline with a little bit of indicami. And you can see that cap I now use is very special. It's also from the Fiji firm, SD hood. I insert the saline into the submucosal layer and dissect it very carefully. As you know, the layer in this part, the gastric layer in this part is very, very thin.
what kind of lesion and what kind of diagnosis do you expect from this lesion?
I'm sorry, I cannot hear from you.
I was asking, what is your suspicious for this lesion? What do you think it will be? The histology.
I think this lesion is just for the endoscopy resection for the submucous tumor, even for the, especially for the cyst, we never cut into the tumor during the whole procedure. Just along the capsule of the tumor.
What kind of knife are you using?
The working station today I used is Viva 3 also from the Urban company. So for bigger vessels, we can use the knife to calculate and cut it. There is no use to change the instrument during the procedure.
Do you change the diathermy mode when you do the coagulation of the vessels?
I never change. So for some bigger batteries, we always use the cochlear grasp for the hemostasis. So here we can see a bigger vessel. First coagulate, next cut it. So we use the cap to exfoliate the tumor and the surrounding tissue. The blue layer is submucosal layer. So here we can see here the bleeding point. So here is a muscle defect in the center of the image. They never cut into the tumor. So here in the center, we can actually the lesion comes from the muscle layer. So I remove the whole lesion with the surrounding tissue, even with the muscle layer. This is a real full thickness resection I want to show you.
So you're going inside the muscular layer without any problem.
I'm not sure.
Could you please do that again? Sorry, there's some delay.
No problem.
And now I removed the lesion from the muscle layer. So in the center of the image, you can see here, this is a defect, and this is a great momentum.
You changed to a coa grasper?
Okay. Open, please, open. Close. Open. Close. Yes, sir. There seems no bleeding now. Open. Close. So next, I will use the nylon loop and the clips to make to show you a suture. Yes. New suture. Again. This is dissected specimen， 好了吗？来，要派一个人来的，一个人要专门来辅助这个尼龙绳，别掉了啊！这个尼龙绳要脱钩最紧一点，这2公分的吗
Explain us the suture you are using now.
？Okay. Yeah, and then suture, thin suture. I use a nylon loop from. Yeah, okay, 放掉。夹子 ，OK， 来一个人辅助这个，来拆夹子，一个人大量的拆夹子，大量的。In China, till now we didn't have the suture device such as OTSCC or overstitch. So we always use the clip open and envelope to close such defects after your prosecuted resection. Open. I still remembered maybe 5 or 6 years ago in Milano, I used 17 clips to close the huge defect about 5 centimeters. Please, okay. 插进去，还没拆，插进去。
This suture method is also called purse suture in literature. When the envelope is tightened, it looks like the purse we use.
正平，开大。The clip comes from the Microtech. You can see this, the tail of this clip is very short. Open, 正平，来，好，好，open，正垂直 ，open， 哎。Blue, fire. One more, please. Open. Blue, fire. One more, please.
The clues for purse suture is to distribute the endo clips evenly around the wound and not to let the clips go outside of the wound.
Is it possible always use a double channel scope to finish such a procedure? But now we can now use the single scope.
Single channel scope.
Yeah. Blue. Okay. 好，别动，准备收。And now I will close the end loop. 慢一点。OK。 Okay. 1, 2, 3, 4, 5, 6, 7. 7 clips. All clips stand on the wound. Close. Close, 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 close. 放掉，放紧，来回5下，松一点，松一点，松大一点。yes， 松大一点，慢一点，对，松大一点。
The tightening goes back and forth to ensure that the wound is closed securely.
So the wound now was successfully closed with several clips and a loop. Like
Fantastic job. We are now changing to the other room. Please, can you explain us the case? Hello, welcome. We have seen a wonderful case.
Maria. Good afternoon. Good morning, maybe in Barcelona. Yes.
Yes.
You can hear me. You can hear
Yes.
me. Yes. Today we prepare one case. It's a submucosal tumor in the EG junction. So the first work, we want to show you the new machine in China we will use in the gastroscopy. It's called EndoAngel. So you see, we use this kind of machine to help the young doctor to fulfill a good case of gastroscopy. The machine was trained by a lot of pictures catched by many experienced Chinese doctors. So he maybe just like AlphaGo, have a lot of experience to focus to diagnose some earlier cancer lesion in gastric, in the stomach or in the esophagus. So you can see we must finish the 26 part, and then the machine can tell us you finish this kind of gastroscope. So it's very interesting one. And now the K, you can see the lesion. I have also do some part. They also have some stories you can see, but in the plane we want to do stir. Just do a turning from the esophagus and then to the funnels of the gastric. But you can see the lesion. The main part of the lesion is in the gastric funnels. So to deal with this kind of lesion in this part, we have 3 methods. If you can see one half is main, one half in the gastric, so you can do the stir. If the main part is in the gastric, you can see when you retrace the gastric scope. Now, today we also use the Fujifilm scope. We can see we have a very good view to deal with this kind of lesions. You can see this lesion, the main part in the gastric. So if you can see the whole part of the lesion, when you retrace the gastroscope, you can do what kind of ESE, just cut from the stomach. Why? You can see the reason, because under the plane, I begin my work use a stir. So you can see I have a opening of the mucosal layer in the esophagus, and then through the submucosal layer, try to find a tumor. But when you very near, very close to the ED junction, you can see the tumor is, you cannot touch it because in the main part in the stomach. So also, this is the experience. You can see the tumor. You cannot see in this site in the 9 p.m. So if you want to do the stir, you can. It's very difficult. And change the method you also can do the case very good. This is the one question. The second question is how to cut it one from the oral version or from the anal version. So you can see if you cut from oral version, the tumor you can very and use they call it a weight and will cut the knife. The tumor will chew by himself. So today I also use the Fujifilm brush knife, and the cap is the what called ST hood. Yes, to shoot this one, you can see if we begin our work from the oral verge. This is the muscle injection. Okay, okay, stop, and then cut. You can see this is the muscle layer. Okay, the white one is the tumor, and use the cap to shoot the margin. The main part of the tumor in this part is the leiomyoma, also the benign one. We, due to our own center experience, the part of the tumor is also the leiomyoma in this one. Okay. Just like to take off the clothes, have the tumor to take off clothes, and you can shoot. Okay. Also, you will meet some kind of bleeding. The main part of bleeding is in the what? Is in the margin of the mucosal layer. You use a cap to help you to elevate the tumor. You can see the muscle, and then cut. 出来，不要动，哎 ，OK， OK。Oh, see the home tumor is go out, and then also use the use the cap. So the scope, I think if the Fujifilm scope have a good flexible feature to deal with the lesion in this kind of case. Okay. And the Fuji and the flash knife, we have the tips for 3 millimeter, maybe longer. According to the indication from the Fujifilm, maybe you will use some short one, but we all like to deal with this kind of case, use some longer one. Why? Because the tumor is have some good, this one. Oh. Okay, okay, okay. Use the cap to shoot the margin, what you want to cut, and then rotate the scope. Then okay, 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 okay. This may be some tips. This is the margin, so you can cut more, and then
maybe we should think in changing of room, because this is really nice. You're almost there.
Changing what? Oh, okay, 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 okay. OK OK， 结束了，我的任务就完成了，是吧？然后把它加起来结束了，对吧？哦，这个倒是蛮有教学意义的，正好是跟大家讲讲我们的观点。很多人喜欢做 stir， 其实这个地方不做 stir 最好，对吧 ？OK， 好了，我把这个也完成了。
To move to the ERCP room and then we come back and you show us the final cut.
OK OK goodbye.
Thank you.
OK OK OK. Thank you.
Thank you. So we will move to the ERCP room. Hello, Professor Deng.
Hello.
Hello.
Yeah. Good afternoon, ladies and gentlemen. Thanks, conference organizer and Dr. Liu Bing of China ERCP for their invitation. I'm very glad to attend the conference. The patient is CBD stone. The US show there is a stone about 1.7 and 1 centimeter stone in the middle CBD. So we perform the ERCP for removing the stone. The papilla is about, I think it's type 3. It's very big and soft. So it's very difficult. We insert the guide wire into the pancreatic duct. So we want to use a double guide wire method to cannulation the CBD. Now I remodel the knife to left like this. Now we cannulation
yes,
for the CBD. OK， 来，好，来，好，来，好，等我看一下，哎，等一下，OK。
小东，你快点，我们要曝光了。
Sorry, the patient is moving. OK.
It shows that they are alive, which is nice for a live
case. Yeah. OK. Yeah. The guide wire into the pancreatic duct. 哎，不用，现在把刀勾一下啊。We adjust. 来 ，OK， 来，好，再来。哎，导师回来，导师回来。导师回到刀了，对 ，OK， 拉到刀里边啊。OK。再拉一点刀，再拉一点刀啊。哎呀，哇塞。We use attachment is made by 太厉害了，太厉害了，放松点，放松点，放松点。对，by Nanjing Microtech。OK。再勾一点刀，再勾点偏，慢点，太厉害，太厉害了，松一点，松一点，哎，对，好 ，OK。好，再来。不，金老师。
好的。
We perform the pre-cut. 哎，不行，拿回来啊 ，OK。哇 ，I think it's very difficult. As we know, the ERCP is a corone of endoscopic technique, but the cannulation is more difficult.
And what are the solutions you use to use in those cases? What is your way of proceeding when it's so difficult?
I think I put the guide wire into the pancreatic duct. I think we have the first step to the success. So I think we can cannulation will be success. I think. Sorry， 来，好，来 ，OK， 再来一下啊，再来一下 ，OK， 来，再试试，好。 哎，好好，不行不行不行，来，哎，对，再把刀勾一下，再把刀勾一下啊，对对对 ，OK， 啊，等一下啊 ，we should separate the knife and the guide wire at the papilla。不行不行，来回来，别再回来，好，再出来。I reshape the knife。哎，这刀工松掉，刀工松掉。OK。Yeah, I think to the left, reshaped.
If you want, we can move to the other room for one moment to see the final cut if you think they are at that moment in any point, and then come back here.
OK， 上，对 ，OK， 等会儿啊，慢点，来，再试，反复试。
And now it's good.
好，现在是有点分开了，好上，好，来再上一点，再上一点，好，回到导览继续上，呀，还是一管，回来，好，来再来，再上，sorry，OK， 来再试，来再上，哎，不行，回来，好，再把刀勾一下了，啊。OK，
一个演示给大家看吧，弄得好一点，到时候镜子很差的，一塌糊涂的，麻烦。
Hello, you are back here. We are seeing you in live.
到我这了 ，Hello Mary.
Hello.
You can see.
Wow.
I have finished my work.
Amazing.
Okay. So the third story, we have third story. You can see when you cut the mucosa layer in the surface of the tumor, so maybe you can close to the ball of the stomach. We can have enough mucosa layer to help us to close the lesion. So you can see we can very easier to close all the lesions, and the patient can go back to his home. And another work, the first work, I want to show you the new machine. They also tell us you cannot see. You can see the machine picture of the endo-angel.
Yes, we are seeing the endo-angel.
Yes, it's very interesting machine. I have used a lot of the colored case because when you do not finish the 26 part, I cannot finish my gastroscope. The machine will tell us it's not a very good gastroscope. So I think it's a very useful tool, especially for some young doctor or for some the part have not a lot of experienced doctor to help us, because all the machine was trained by a lot of picture captured by experienced doctor, just like Professor Zhou and also Professor Lin Hu, maybe have 20, 40, maybe 30 years experience. So I think it's a very interesting one. You can see it can help us to show this one. And if you find the earlier cancer lesion, you will have some tips. You can see. I just have an example because it was bleeding after the operation. So if you have some abnormal mucosal lesion, you will have some tips, and then you must stop and get it and let the scope to focus to see if have some cancer lesions, and if you cannot give a good diagnosis, you can do the biopsy. So I think it will help us very useful. You can see in our endoscopy room, we have 1, 2, or 3 screen. It's very like we see in the movie, in the Hollywood. I think just because I also very interesting for the Philip Jones robotic surgery. Maybe 4 years ago, maybe 2 years later, in the 2023, we also can use robotic surgery to do this kind of lesion. We do not need the caps. Only use 2 hands to help us to cut this kind of lesion. So I have finished my work.
Really impressive. Congratulations. And really nice to see the images with the Endo Angel. It was very illustrative. So thank you very much.
Yeah.
We will go now to the RCP room. Thank you very much.
再加，讲完了，完成了 ，OK 了。我夹子，透明帽没有取出来，标本，先取透明帽。透明帽掉了，一开心透明帽掉了。哎呀，回家，唉。
You are still on the screen, and they are probably moving to the RCP lesion session, but you are still on the screen.
好 ，OK， 好，来，刀工松掉。呀，来，好，拍点造影剂啊，可以，慢点，拍点造影剂。
Hello, Dr. Fang. You are again on the screen, on the air.
Yes, we successful cannulation into the CBD. OK, we OK， 来，对，打一点。OK。
How did you do it? Okay. Did you do any special different thing?
Sorry?
Did you do any special, did you do something different to get into the bile duct?
我听不太懂。OK. We can see the lower CBD is maybe have a stricture, but they're not not above where stone. Okay. The US show maybe here is a stone. Okay, we can use a balloon to remove or to check the stone. OK， 慢点。OK， 我们用气囊，取式球囊。OK， 取式球囊。OK， 好。
So you had an EUS before for this patient?
Yes, the US show maybe there is a little smaller stone at middle of the CBD, about 1.7. 1.0 millimeter. But in the flow, I don't look at obvious stone. So we use a removal balloon to check.
Good.
拉住。导师太深了啊，拉住一点。哎，对 ，OK。啊，好，来 ，OK。哎，看着爱光，好，来，打，啊，打一点。打，好，再打，继续。还没起，继续，光。OK。可以。
You can see that very nicely the balloon going on the X-ray, how it's inflated.
小一点啊。再小一点啊 ，OK。那没有一个明显的石头是吧？
Do you feel any tension?
放掉，我们再拉一遍。We do not find. 等会慢点啊。OK， 对你导师拉一点啊。OK， 来。Once again.
And when was the US performed? Was it many days ago?
Yes. Okay. But there is not obvious ultrasonic shadow, not very stronger. It's very weak, so we don't think it's a very hard stone. Maybe it's a muddy stone. I think so. Okay.
So thank you.
再小一点。
We're going to close the session.
OK， 来。
And we're going to go to a lecture video on an AI lecture. So thank you very much. That was really interesting to see the difficulties that we can find sometimes in real life. And we will move to this video session on AI.
Mr. Chairman, ladies and gentlemen, good morning. My name is Hong Gang Yu, come from Renmin Hospital of Wuhan University, China. So the topic I would like to present here is a new development of endoangio. In fact, the new development about the endoangio is the application of artificial intelligence in